Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Training Clinicians to Address the Grief of Overdose Death. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen only and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days. To access the recording and PowerPoints and other materials, please go to www.fada.org, then to our Resource Center, and then to our training library. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note the evaluation will close midnight, Monday, May 30th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide partial CE credit if you do not attend the entire webinar, and we are not permitted to provide it if you do not listen. Susie Kowalski has been serving stigmatized communities for more than a decade through direct clinical practice, as well as by delivering training and consultation to students, service providers, and administrators. Susie has worked in community mental health organizations in Chicago to develop and implement new programs combining her clinical expertise with administrative and organizational skills to launch trauma-informed programs based on principles of harm reduction. Susie applies her experience as an outreach worker, substance use counselor, trauma therapist, clinical supervisor, and program manager to develop trainings for a broad range of workers with different roles, experience, and expertise. As a therapist, clinical supervisor, trainer, and consultant, Susie emphasizes a relational approach in which healthy connection facilitates the development of insight, practice of new skills, and curiosity for continued growth. And now I'd like to welcome today's presenter, Susie Kowalski.
Hi, good morning, everyone. Thank you so much for having me. And I want to make sure to thank Rebecca and Eric and everyone else behind the scenes at FADAA for all of your work to make all of this come together. It's definitely a team effort. And I also want to make sure to thank the Florida Department of Children and Families for sponsoring today's presentation. So it's always a pleasure to work with you all, and I'm really glad to be here. For today, we're going to talk about what it means to address the grief of overdose death. And this is a big and heavy topic, but a really important one. And a little bit about my background that's pertinent to today's presentation is that, as Rebecca said, I've worked in community mental health and substance use treatment in Chicago for more than 10 years. And I have unfortunately had the experience of losing clients to overdose death. And it does leave this hole and this question of sort of what do we do with that and how can we feel better prepared to address these situations as they come up. So I am looking forward to talking with you about this because I think it's a really important topic to set aside some time for us to discuss. So we'll dive in shortly. I run a company called Practice for Progress with my husband, James Kowalski. He's also presented webinars for FADAA. And so here's my contact information. Feel free to reach out if you have questions. As Rebecca said, feel free to enter them into the chat as we move along today. But if you have any questions or comments after the presentation today, feel free to contact me. I'm always happy to be a resource to folks and to hear from people. Okay. There aren't any actual or potential conflicts of interest to disclose today, and this presentation was created without any commercial support. So here is somewhat of our roadmap for today. We'll be talking about kind of starting from a preventative approach of how do we implement some trauma-informed policies and practices in order to acknowledge the reality of drug overdose death and to really highlight prevention efforts. We'll talk quite a bit about different protocols that we can implement in the event of a drug overdose death and how do we respond to that. And then we'll wrap up by talking about grief and mourning and talk about different tools and resources to be able to work through the grief that comes with any loss, but particularly with loss from overdose. And in the context of a clinical setting, it's pretty different to lose someone as a clinician than to lose someone in our personal lives. So I want to start with a poll for all of us to get a sense of who's in the room and what our level of exposure is to overdose death. So you should see a poll pop up, and it's just a simple yes or no. Have you lost someone to overdose death, either in your personal life or in your professional life? So I'll give you all a moment to enter your response in the poll. But I wanted to get a sense of, you know, for those of us who are in this room today, what kind of experience are we bringing? We hear quite a bit about overdose and overdose death, and I think sometimes because we hear about it so often, we can start to feel a bit numb to the statistics. We also know that it's not an abstract, faraway experience. It's something that many of us in this room have been touched by, and it's something that we carry along with the knowledge that we may experience additional losses to overdose death. So I'll give you all a few more moments to go ahead and fill out the poll. But I think our exposure to overdose death is a really powerful reminder that there isn't this divide between us and them. It's us and us. We're all affected by this, and we're really in this together. So Rebecca, if you can go ahead and close the poll, we can see the results. Okay. So it looks like a really significant majority of you have experienced loss to overdose death. I'm not able to see the exact percentage, but almost
Susie,
half of the folks. And yeah,
I can tell you the percentage if that would be helpful.
that would be great. Thank you.
So for yes, 40%, and for no, 25%.
Okay. Thank you all for your responses. And, like I said, I think the experience of overdose death is something that really sticks with us. And so I'm sorry that there are so many of us in this room who've gone through it. And I think that really highlights the importance of spending some time talking about this topic. So I want to bring us to some statistics. So this is looking at a national level, and we've seen that nationally overdose deaths have really continued to rise very steadily, and during the pandemic have actually escalated. And so this is data looking at the 12-month period ending November 2021. So from November 2020 until November of 2021, nationally, there were just over 102,000 people who died from drug overdose. And again, I think it can be easy sometimes to get lost in the numbers because that's a really big number to try and actually bring meaning to. But these are human lives that have gone in a way that was preventable and often quite sudden. And then this is data for the state of Florida, looking more locally during that same time period from November 2020 until November 2021. There are just over 7,700 Floridians who died from drug overdose. And so, these are human lives that are gone and leave in their absence family, friends, and other loved ones who are in mourning. And I think it's hard to know what to do with that grief, especially when we think about it on such a large scale. And then kind of bringing it back to our topic today, what do we do about that when it happens in the workplace? And we have this really unique and sort of in some ways unusual relationship with the people we work with. The boundaries of our work are set us up to feel close to people and to have a lot of close contact with folks, but there's also boundaries that create quite a bit of distance for important reasons, but it makes it confusing for us in terms of then how do we mourn. So we have another poll that hopefully will pop up in just a moment, but for those of you who have experienced drug overdose fatalities at work, I'm curious to hear, did your workplace or program offer support and resources to help you process that loss? And so we have A, yes, I did have those resources and it helped. B, yes, I had those resources, but it wasn't the right kind of help and wasn't effective. Or C, no, I didn't have that at work, but I got help and support in other places. Or D, no, I wasn't offered support or resources. So I'll give folks another moment or two to enter your response into the poll. And then while we're waiting for folks to complete the poll, I'm curious in particular if you did receive effective support at your workplace around a drug overdose death. Feel free to enter into the chat what kind of support that was. And Rebecca, you can go ahead and close the poll. But one of the things I always appreciate about these webinars with FADAA is that it's a really great opportunity for resource sharing. So if you'd like to share with others how your workplace has supported you, go ahead and enter that into the chat while we wait for the poll to close. Okay, and so Rebecca, again, if you are able to read off the percentages, that would be helpful.
Of course. So to answer A, we had 16%. To answer B, we had 3%. To answer C, we had 10%. And to answer D, we had 10% as well.
Okay, so it looks like, there's a fairly even split here. And unfortunately, what we don't see is what we would really hope to see, right? As an overwhelming response of, yes, I got really effective help, and it really supported me in working through this difficult time. So I think that kind of highlights the need for our conversation today. So I'm sure that I don't need to tell you that you are all frontline workers in the midst of a crisis. And we hear all the time about the overdose crisis and the increasing number of people who are dying because of drug overdose. And that means that if you're working in substance use treatment, your job means that you'll often be exposed to trauma in the form of sudden, preventable, and unintentional death. And that you'll be working directly with people who are also exposed to that same type of trauma in their lives. So even if you don't experience overdose-related deaths directly, it's very likely that the people in your program have lost someone to overdose. So what we're talking about here is a frequent exposure to both direct and vicarious trauma. And because we know that this is the case, right, we can expect that if you work in substance use treatment, you're likely to be exposed to overdose death in some way or another. It means that we can plan for it, and that treatment programs really can and should implement protocols to prevent overdose and overdose death. And the unfortunate reality is that they also need to have really clear and well-established protocols for how to respond in the event of an overdose death. If we know that substance use treatment workers and the people they serve are likely to be exposed to trauma, this really underscores the importance of adopting trauma-informed approaches to our care. So what is trauma-informed care, and what does it look like, and what does it mean in the context of this particular type of trauma, of exposure to overdose death? So I am a big advocate of trauma-informed practice, and there's a big part of me that really loves to hear about trauma-informed care so often these days. I think it's really burst into the public consciousness, and we hear about it a lot more than we did just 5-10 years ago. The catch, though, is that everyone wants to be trauma-informed these days, but we don't always have a lot of consensus about what that means and how we're defining it. So I really like this definition. It comes from SAMHSA, and they talk about the 4 R's of trauma-informed care. And this definition tells us that in order to be trauma-informed, we have to first realize how prevalent trauma is and understand how people recover from it. So we'll talk a bit more on the next few slides about what this looks like in the context of overdose death. So we'll kind of expand on that in a moment. The second component is that we need to be able to recognize signs of trauma, and not just in the people we serve, but also in their families and communities, as well as within the people who work in our programs. How do we know when staff have been affected by trauma? And there's a lot of different material on this, and if you've been to any of my previous webinars, you'll know that I almost always touch on this at least a bit. And it's also really complex because everyone responds a little bit differently to trauma, and even the same person might respond differently to different traumas or different traumas at different times. So what I really like about the SAMHSA definition is that it makes a point of including staff and really directs us to look for signs and symptoms of vicarious trauma. Beyond just knowing how widespread trauma is and being able to recognize it when we see it, we also need to then respond appropriately. So what kinds of policies and practices do we have in place to address the trauma of overdose death? Do staff know what to do in the aftermath of an overdose death? And we'll talk quite a bit about different protocols for responding to an overdose death later on. And part of the reason that we want to have these things in place is so that everything and everyone that needs to be taken care of gets taken care of during a crisis with a lot of different moving pieces. But also, I think not having to come up with these steps and think these things through during a crisis alleviates a small part of the burden on staff. It certainly doesn't remove the traumatic impact of an overdose death, but having these protocols in place is really responsive to the reality of this kind of trauma. And then last, and arguably the most important component of being trauma-informed is that in order to be trauma-informed, we have to be really proactive about resisting re-traumatization. So in terms of overdose deaths, I think what that looks like is, how do we try to prevent overdose? How do we try to prevent fatal overdose? And in the event of a fatal overdose, what can we do to reduce the likelihood of that event becoming the source of additional trauma for the people who are involved? So I want to back up here to that first R, realizing the widespread impact of trauma. For those who work in substance use treatment, I think what that really looks like is that we need to be talking about drug overdose and drug overdose fatalities. We don't want to contribute to a code of silence around it. And as much as possible, we want staff to feel prepared for the possibility of there being an overdose death in the program. And so this means that we really need to be naming the reality of drug overdose, whether they're fatal or not, at all stages of people's work. So when we're hiring, we should ask candidates about previous experience with drug overdose. As we onboard new staff, we need to be sure to train them in overdose prevention and response, right? We want to make sure staff are really well-versed in talking about drug overdose prevention. They should know like the ins and outs and feel really comfortable talking to service recipients about it and have a really nuanced understanding of prevention strategies. We also want to make sure that staff are able to really clearly describe and identify signs of overdose and understand how that differs from significant intoxication, and then also know how to respond. So this definitely needs to include use of naloxone. And I'll say about that, I think an important part of it is including the physical act of drawing up a syringe and administering it, because unless your program has the funding to always have Narcan, which is the nasal spray version of it readily available, most of us are not medically trained. It's one of my favorite disclaimers to give that I am not a medical professional. But the last thing we want is to be witnessing an overdose, to have naloxone on hand and not be able to administrate it. And in previous jobs, I've had to really advocate with administrators to allow staff to practice with actual syringes. So drawing up water from vials and injecting it into either a styrofoam cup or an orange, because both are supposed to be similar in texture to human skin. Because for a lot of folks, that is actually the trickiest part. How do you get the medication into the syringe? And if you haven't had a lot of time to practice and really get the feel of it and build that muscle memory and understanding of how to do it, you're not likely to figure that out in the midst of a crisis. So similarly, if your program can afford to have Narcan, the nasal spray, available for all staff, even then, I think it's really important to actually show people how to use it. We don't want to be wasting doses, but I can say I have administered Narcan, the nasal spray, during an overdose. And even though it's pretty straightforward about how it works, it's still helpful to not have to sit there and figure it out or question if you're doing it right while someone is overdosing in front of you. So we want staff to feel really prepared to respond to an overdose. I would also say that part of onboarding, as well as a regular ongoing part of staff training and support is making sure that folks are really familiar with protocols for responding to an overdose, including overdose fatalities, so that if and when the time comes, they aren't left grasping for straws and trying to figure out next steps in the midst of an unfolding crisis. Overdose events, whether they're fatal or not, they're really stressful and really challenging. And we want to have staff who feel as well prepared and as well resourced as possible. And so I think having a strong sense of efficacy and preparation really helps minimize the impact of these traumatic exposures. And then, similarly, we need to make sure that we address the risk and prevalence of overdose deaths with the people that we serve in our program. So we aren't doing this to try to scare people into making different choices. We're naming the reality of overdose death and offering transparent, neutral, and clear information to people so they have as many resources as possible to keep themselves safe and to cope with the potential for witnessing or hearing about the overdose of someone that they know. So as part of the intake process, we want to be asking about people's experience of overdose, either theirs or others, and really assess for the level of support that they were able to access and what types of prevention strategies they know of, and then also which ones they implement. If people contact us about treatment, but we need to put them on a wait list, we want to make sure that we still talk to them about overdose risk factors and prevention strategies. And if your program allows, it would be amazing to also provide them with naloxone. We want people to stay alive while they're waiting to come to treatment. We'll talk about this more on the next slide, but we know that when people are seeking treatment and when they're in treatment, they're really likely to be making changes to their use, which actually puts them at an increased risk for overdose. Like I said, we'll talk about that a bit more. But overall, we really want to emphasize overdose prevention and response strategies and make sure that our participants know that we care about them and we want them to stay alive, even if they're using in ways that we wish they wouldn't, and that we'll support them if they or someone they care about experiences an overdose. We want the people in our programs to feel safe coming and telling us if they overdose or if they witnessed an overdose or lost someone to overdose. We want them to really trust that we're not going to shame them about it the same way that we wouldn't shame folks about experiencing other types of traumatic events. One of the things we know in all of our research about trauma is that connection is a really strong mitigating factor when people have experienced trauma. So we hope to maintain connection with people, even and especially when they experience the trauma of an overdose. So there's this interesting idea of this paradox of treatment that when someone goes to treatment, it makes sense that we would think their risk for overdose decreases, right? They're presumably at a place of some increased readiness for change. They're accessing support from counselors that can help them manage cravings or urges. They might be prescribed medication that can manage withdrawal. They're getting information about overdose prevention, and, very possibly they're using drugs and alcohol less often. The paradox, though, is that by changing their patterns of use, they're also changing their tolerance. So if you're using less than you were before, our tolerance is going to quickly lower. And with a lower tolerance and different patterns of use, the risk for overdose actually increases. So again, this, I think, really highlights the importance of training people on overdose prevention strategies and really widely distributing naloxone, including among people who are no longer using, because those are some of the folks that are going to be at the greatest risk for overdose. I think for me, one of the most challenging components of overdose drug fatalities is that I'm definitely a harm reductionist, but we know that drug use doesn't have to lead to overdose, and overdose doesn't have to lead to death. We can prevent overdose by really partnering with people to understand their use and to strategize with them about overdose prevention plans. And even if someone does overdose, it can be reversed and their life can be saved with naloxone. So naloxone distribution and overdose prevention, I think, is one of the most empowering ways I've seen to really partner with the people that we serve to reduce overdose deaths in their communities. And the reality is that people who use drugs are most likely to be around when an overdose takes place, which also makes them the most likely to be able to save a person's life. So I think of a particular person I worked with when I worked in substance use treatment on the west side of Chicago, which, if you don't know, is a community that's really been ravished by overdose death. And I think of one woman in the program in particular who we trained on overdose prevention, and we gave her a naloxone kit, just as we did with nearly everyone. And a few days later, she was waiting at a bus stop, and she saw someone who was slumped over. She recognized that he was overdosing. She administered naloxone, and she saved his life. And it meant so much to her to be able to save someone's life, and to do it right there in her community really made her feel like she was helping to create change in her neighborhood and to be a part of an effort to keep people safer, and to recognize that, you know, whether this person is using or not, she didn't want him to die, and she didn't want more overdose deaths happening in her neighborhood. So I know I've talked a lot about overdose prevention already, but that's really because when posed with the question of how do we train clinicians to address overdose deaths, one of the biggest parts of that answer is we train them to prevent overdose deaths. That being said, the unfortunate reality is that many overdoses do result in death despite being preventable. So what do we do in those situations? In some ways, we have to follow a lot of the same steps that we would take anytime someone in the program dies, regardless of the cause of death. And there are also some unique components when the cause of death was a drug overdose. We'll kind of walk through it, but coping with the aftermath of a fatality isn't necessarily a linear step-by-step process, even though we're going to walk through it in that way. I think it's important to name that that's not how things typically unfold. In the moment, there's a lot of really dynamic and fluid demands that overlap with each other or kind of repeat themselves or influence each other. And then I think there's also very often with death, there's a need and a desire to both slow down and take some time and have some sense of stillness, and then a simultaneous pull and demand to speed up and move quickly. And I think to some degree that's a reflection of trauma. Trauma kind of pulls us to these extremes. So we have to deal with the practical aspects of the situation as it unfolds. And we also know that we also want to give space for service providers to cope with their own reactions. So ideally, there's going to be a protocol in place to help guide the process, but there's almost always going to be some nuanced details that providers need to really address and figure out on the fly. And in general, I think there's a balance of needing to take care of essential job duties, so things like the urgent needs of clients, any sort of paperwork, things like reporting that needs to happen, We need to kind of clean up the scene and restore order if it happened on site or if there were paramedics involved or resuscitation attempts. So that also includes kind of managing a crowd if there were other people around, including staff, and then also making sure that we inform other people who need to know that the fatality occurred. So there's this guide that you see at the bottom. It's linked here and it's cited in the resources, and it's about coping with overdose fatalities. And I find it to be pretty helpful, and it offers these 5 core actions to focus on that are not part of a step-by-step protocol, but more overarching. These are things that we want to focus on as you move through the steps and stages of the protocol response. So we want to promote safety. This can be through focusing on basic needs like food, water, medical attention, sleep. We also want to think about emotional safety and protecting people's privacy, and then definitely reiterating overdose prevention strategies and assessing for coping strategies, but don't necessarily just focus on using substances to manage distress. We want to promote a sense of calm. So it's a good time for us to take a couple moments to really ground and center ourselves and be able to suggest and model strategies that bring calm, to normalize intense emotions, and to only share information that we know is accurate. There can be a tendency during a crisis to speed things up and say a lot of the bits and pieces of information we heard. And part of this calm is, I think, being able to be thoughtful about what do I actually know, what information does this person need, and not, contributing to this sense of like chatter and sort of busy chaos. To promote connectedness, we want to offer our sincere attention and to be present and very attentive to folks. We can really create opportunities for people who've had similar experiences to be together during these times, or encourage folks to be in touch with their key supportive people in their lives. And we certainly, with our staff and the people in our programs, we want to reiterate our care, our concern, and support. We want to promote hope. And this one I think is challenging because we want to do it in practical ways, and we want to avoid like platitudes and predictions. So I think these are good opportunities to really reinforce or elicit from people their strengths, assets, and resources. And then we can promote self-efficacy by really focusing people on immediate next steps, helping to encourage small, achievable, and incremental steps, partnering with people and allowing them to make meaningful decisions, taking some, and being able to offer people choices related to decisions planning and taking action. During a crisis, especially during an overdose death, there can be a lot of feelings of helplessness. So we want to draw attention to the areas where people do have efficacy. So in the next several slides, we'll walk through this protocol in more detail. And this protocol comes from the link cited here, and again in the references, about a clinical response following an opioid overdose. So first, we want to manage the incident itself. Then we'll focus on notifying staff and holding a staff debriefing. We will then notify and support other service recipients because we know they're usually going to know what happened and we want to support them. We'll reiterate overdose prevention and response strategies, and then review agency response and revise the protocol if we feel it needs to be. So the first step is just managing the incident. So this is things like notifying all the departments that need to be aware, like quality assurance, following any kind of reporting requirements, I know in Chicago, there's a specific form if there's an overdose fatality so that it can be appropriately tracked. And then as soon as possible, we want to assemble staff members to let them know. These are kind of like the immediate needs. We then want to notify as many staff as possible as soon as possible. So ideally, the acting supervisor would deliver the news individually to staff members in person, but if that isn't possible, individuals should be called and given the information. I will say I am not in favor of calling people on their time off to notify them. I think that's one of the ways we can respect people's boundaries related to work. So typically we want to do it at the start or right before their next shift so that they're aware of it as they come into work. If it's, during a work day, we want to let people know as soon as possible. Ideally, we then organize a staff debriefing within a day or so. And this is where we want to gather all of the staff members who were either involved or affected. So depending on the size of your team, this might be most of your team, but we want to have as many people as possible there. And this is just for staff, to clarify. So the debriefing is relatively short, like maybe 30 to 60 minutes, and it's not the time that we're going to fully unpack everyone's reactions, and this is also different from a time to really memorialize the individual. The purpose is more so to ensure that everyone involved has all of the information. So we're going to talk through, in kind of a factual way, like the who, what, when, where, why about the death. We might go through and identify key factors in the person's treatment. It's an important time to gauge staff reactions and get a sense of how people are responding. But again, it's not the time necessarily to fully unpack all of that. We'll talk about that in a moment. And then this is also where we want to identify any immediate follow-up action items that need to be addressed and taken care of. The supervisor also wants to make sure to schedule one-on-one, again, ideally sooner than later, to meet with the responsible clinical staff member to offer additional support. So again, this is where we're just trying to get a sense of make sure everyone's on the same page and what information might people need, and then also what support might people need so we can gather and then implement those resources. So we know that people respond differently to traumatic events, especially loss. So we want to really normalize people's strong feelings and affirm that there isn't any right or wrong way to experience loss. And that's something that we may hear and know intellectually. And when it happens, it can be hard for people to sort of integrate and recognize that. And so we want to be a good reminder that there's no right or wrong way to feel your way through this. And it's going to look a little bit different for everyone. It's also a really good time to reiterate the importance of self-care and community care, and to encourage staff to practice coping skills, to really elicit from them what has worked for them in the past, and then to model and identify skills together as a team. So I know we've been talking about a lot of heavy material, and we have more heavy material to come. So I thought this would be a good opportunity for us just in the here and now to practice a brief grounding exercise together. So I'm going to ask folks to sit in a comfortable position. And this is a helpful way to just sort of bring ourselves back into our bodies. We've likely, practiced or used this before, but so it's often called just the 5, 4, 3, 2, 1. But I find it to be really accessible because it is so simple. We can do it anywhere. And it's just a helpful way to kind of bring us back into our bodies when we start to feel like we're either floating or kind of spinning out. So just take a couple of breaths, and I'm going to ask you to bring your attention to your sense of sight. And just look around the room where you are, and likely you've been in this space before, but to notice 5 specific things that you can see with your eyes. It might be your computer monitor, other things in the space you're in, but name 5 specific things you can see with your eyes. And now shift your attention to your sense of touch and feel, and identify 4 specific things you can feel with your body. So that might be the sense of your feet on the ground, your clothing against your skin, the 4 things you can feel with your body. Now bring your attention to your sense of sound and identify 3 specific things you can hear right now. My neighbor's dog might be one. And now bring your attention to your sense of smell and notice 2 things that you can smell with your nose. And then last, bring your attention to your sense of taste. And try and see if there's a specific taste that you can become aware of. Okay. So hopefully you got the experience of it. Takes just a couple moments, but it kind of helps us bring us back to the here and now and to feel a little more grounded in our 5 senses and in our bodies. So moving through the protocol, the next step is to notify and support other service recipients. So we want to set up a time to talk about what happened, either with the people who are directly impacted, either in a group setting or an informal group meeting. If you're, in an IOP, very likely you're going to have a group. And very often people are aware of this. And so there is a balance of, people's right to privacy still exists even in their death. And very often people are going to come into the program saying, I heard so-and-so died, or I heard so-and-so overdosed. And so we want to hold space for supporting them in that awareness. We want to give folks enough time to discuss the loss, and then arrange a time to hold a memorial if service recipients and staff are interested. I found this to be a really powerful event, and we'll talk a little bit more about it later, but it can be a really good opportunity to actually include other service recipients in planning the event. But it's a nice way for people to come together. So in the initial steps, we might just be, setting a date for it. We want to follow up that group session right away with any clients that seem really impacted, and kind of keep our eyes out for people who might need additional support. We want to make sure that staff are following up with everyone on their caseload and their next individual sessions to discuss the reaction. And some people might not really have a reaction, and that's fine. We don't need to belabor it, but we want to at least open the door for people, because there will be some folks who will really have quite a reaction. And in my experience, it's not always the people you would expect. It's not necessarily a level of closeness, but maybe someone was used to buy from that same dealer or something like that, but they have some sort of connection and it stirs things up for them. And then we want to come back together as a treatment team to talk about any concerns or observations we have about how service recipients are being impacted. In discussing the event with other participants, we don't want to speculate and kind of open the door to what was going on. We want to, again, keep things factual while respecting the person's privacy. Mostly, we want to focus on the reactions of the group and being able to validate and process their feelings. We want to avoid using the person's death as a cautionary tale. That's not a respectful way to talk about someone. It's not an effective way to make changes to other people's use. But when we are stirred up and upset, it can sometimes be a temptation. But it's something we want to really avoid because it kind of limits the humanity of that individual. And then we definitely want to make sure to really assess for and identify anyone who's going to be especially impacted. Like I said, it's not always who we would suspect, but we want to be able to check in with them right away and schedule additional sessions as needed. And with everyone, we do want to make sure that we reiterate overdose prevention and response strategies, make sure folks have naloxone, that they know how to use it, and have a clear sense of how they might prevent overdose themselves. So that is the next part of our protocol. It's to really reiterate those prevention and response strategies. So we want to retrain people. It's a kind of useful or timely opportunity to make sure everyone knows how to administer naloxone, make sure everyone has kits if you distribute them, if not, offer prescriptions. But I find it to be helpful to really get into the finer details with folks of making sure they really know how to actually get a kit in their hands. And then we want to really reinforce the importance of overdose prevention strategies, including use of naloxone, but I think it's also a good time to talk with people using kind of that motivational interviewing provide elicit framework of what sort of overdose prevention strategies are you already using or are you aware of? Could I offer you some other information or suggestions? And then elicit, what do you think you'll incorporate? But being able to really talk with people in detail about different components of their overdose prevention plan. We want to talk about risk factors for overdose. I have always been, not always, but I've often been surprised in working with people who have used substances for many years, and that sometimes there's a real lack of knowledge about risk factors. And there's a lot of myths that exist out there around, you can't overdose unless you're injecting or different things like that aren't true. So we want to make sure people have factual information about risk factors and a clear understanding of them. And then we know that any kind of loss, but especially overdose loss, can become a potential trigger for use. And so we want to identify folks who might be at risk for recurrence of use or increased use to talk with staff and make sure that we're supporting them. Okay, and then kind of the last part of this protocol is that we want to really look at, to kind of wrap up this protocol by checking in around how did this protocol work? Are there any sort of changes we might need to make to our policies or procedures? Did people not know about the protocol? Are there parts of it that rolled out really smoothly? Were there parts of it that were particularly bumpy? Are there any additional supports we can offer to people? I've worked in programs where we've been able to bring in a grief counselor. Sometimes there's also after the initial staff debriefing, there can be another session shortly after dedicated more to processing staff's reactions, giving them a little more space to be able to talk through how they're doing. Are there any obstacles to getting professional assistance? So we want to just sort of review how things went and see if there's any changes we want to or need to make. Similarly, I think we also want to think about in the next days and weeks, are there any adjustments we need to make to people's work situations? Do we need to offer people time off? Do we need to facilitate peer support? Do we need to reassign tasks? In the midst of a crisis or in the immediate aftermath is a really good time for supervisors to offer to maybe do closing paperwork, take some of those really administrative burdens off of someone, if we can help prioritize different tasks, just different ways that we can support individuals, recognizing that this is a human loss and that they are going through it. And they're still at work and still trying to support other folks, but being able to really kind of honor their humanity and give them space to go through their own grieving process. And then once again, we want to think about any relapse prevention considerations. I think certainly for staff and program recipients, but I think the family and social supports of the deceased person are really key people who can often be overlooked. And I think those are also folks we want to be thinking about proactively. There might be family members or household members who are not engaged in substance use. We want to make sure that they have a naloxone kit and know about overdose signs and feel comfortable to administer naloxone should they need to, because they might be available and there when an overdose occurs. So we'll wrap up our time today talking about grief and mourning, but we can, if there are any questions that have come in, Rebecca, now would be a good time. And then after any questions at this point, we can take a quick 5-minute break before we come back and transition to discussing grief and mourning.
Susie, I don't have any questions in my chat right now, but if any come up, I will let you know.
Okay. Well, why don't we go ahead and take our quick break now, and then we can come back and discuss what it looks like to go through grief and mourning. So I believe we take a 5-minute break.
That's correct.
Yep.
We'll come back at 7:04.
Okay, sounds great.
And I put it in the chat for everyone as well. Welcome back, everyone, to today's webinar. Susie, I will turn it over to you.
Great, thank you so much. Okay, so we've talked through different protocols that we have to help guide us through the immediate next steps after an overdose fatality. But what comes next, right? There is not a step-by-step guide to grief, but it's a really important and significant part of our experience with overdose death and of death in general. So we'll focus our second half of our time this morning talking about the grieving process and the ways that it's different when we experience loss as clinicians and when we experience loss due to overdose death. So what is grief? It's a set of experiences that involve a perceived loss that someone has around loss of a person, a situation, an event happening, and that it changes the way that that person physically, emotionally, and spiritually reacts and responds to the world around them. So I found it helpful to understand that grief is an internal experience. It's what we feel in a lot of different ways. And mourning is the outward expression of grief. We often hear about grief and mourning, so I didn't know that distinction, so I thought I would make sure we know, share that with you. We tend to think of grief as something that's really associated with death, but what we see here and what we know intuitively is it's really a reaction to the loss of anything or anyone that we're deeply attached to. So we can experience grief over the loss of a relationship or the loss of a job or a sense of community. And I would say that when clients die by overdose, we can often experience grief as clinicians, not just of them and their life, but we also experience the loss of a sense of hope for their future or for their recovery. We also know when we think about it and when we look closely that grief is much more common than we really acknowledge. And like stress, positive life events can bring on feelings of grief. So almost any time that we experience change, we can experience grief. We might grieve the loss of independence or loss of a past life or loss of a previous stage of life. Again, even during happy moments like getting married or watching a child graduate from school, when there are life transitions, there's inherently things that we leave behind. And so any kind of major change to our normal routine can trigger a grief response, which means that as people who work with people who are literally coming to treatment in order to bring about some kind of change to their normal routine, we're going to be working with people who are grieving. And I think most of us don't think of ourselves as grief counselors or necessarily have any specialized training around it. And in general, I think grief tends to make us uncomfortable. But the nature of our work means that we're going to be surrounded by grief. And if we avoid addressing it or become uncomfortable, it can be a potential pitfall for disengagement with clients. But if we're able to really embrace grief work as an opportunity for connection, we can strengthen our skill set in being able to support the people that we work with. So, like I said, the reality is we're going to be working with a lot of people who are grieving. And the more we can become familiar with grief and be able to hold space for it, to be able to hear it when people are talking about it without naming it, sort of like trauma. Can we recognize it when someone doesn't come out and say, I'm grieving, or I'm really struggling with the loss of my using self, or people who I felt connected to who don't support my recovery plan? There's a lot of grief and loss within that. Are we able to recognize that this person is going through loss and be able to talk with them and support them around it? I think especially for something really complicated like substance use, we might tend to really cheerlead and champion positive changes. We also want to make sure that we're opening up space for the loss that people are also experiencing, and that being able to work through their grief around that loss is a part of being able to move through it. So I like this idea of a grief fire drill. Like, we practice fire drills so that in the event of an actual fire emergency, the skills that we need to use aren't new and foreign to us. We already know what to do in that situation, even if we haven't necessarily experienced it in real life before. And in general, when someone is grieving, I think most people would say they aren't really sure what to do or say, even when they want to be helpful. And so I think sometimes these conversations about grief feel scary and dark to us because we aren't used to them, and labeling grief tends to bring this dark cloak about things. A reason that we really want to get more comfortable with our own discomfort and be able to practice talking about grief so that when a crisis occurs, we aren't feeling our way through grief and conversations around it for the very first time. So we're going to watch a video that shows a lot of people talking about what grief feels like for them. And as we get the video loaded up, one of the things I want to name is that grief feels like a lot of different things to a lot of different people, as you'll hear. But I also want to note that a lot of the same feelings that we are used to working with are a lot of the things that people are naming. So for some reason, it just feels harder for us to address when it's related to grief. But as you listen to these different emotions, I think it's helpful to think about, oh, I've worked with someone who's going through that, or this does or doesn't feel as familiar to me. So let's take a look at what grief feels like. Okay. So like I said, grief is a complicated emotional experience, and as we'll talk about in a moment, it's not just an emotional experience. But I think it's helpful to sort of look at that video through the lens of, I've worked with people who've experienced emotions like that. I think it helps make it feel a little bit less intimidating and foreign for us to work with when we recognize it's actually a lot of the work that we're very accustomed to doing and that we do on a very regular basis. So I think it can be helpful to think about grief across these different dimensions. People grieve in different ways, and they also have different coping styles for processing their losses. And as I've said, there's no right or wrong way, and people aren't going to grieve only across one dimension, but I like this framework to give us some expanded ways of thinking about how people may experience and process their grief. So at the cognitive level, people will talk about this idea of grief fog, where sort of like I've seen it in the literature as mentioned as being kind of akin to like pregnancy brain, where there's a lot of difficulty concentrating, your memory may be impacted, people have difficulty making decisions, their focus might be impaired. It can be hard to think about the future and to think about future thinking or planning. There's sometimes a sense of confusion, some difficulty processing information, and sometimes this like altered perception of time, where it's unclear of like, was that yesterday? Was that a month ago? Was that weeks ago? And things just feel sort of fuzzy. At the emotional level, I like that video, but we see things like anger, guilt. We also hear about joy and gratitude. There's confusion, fear, hope, resentment, a sense of yearning. Sometimes we hear about envy, numbness comes up a lot, frustration, anxiety, sadness, and even relief. And I think, especially at the emotional level, but also cognitively, different thoughts that people might have about their own reaction or their relationship to the person who passed away, or their thoughts about them. There isn't a right or wrong way to feel. And I think part of our role is helping people recognize their permission to feel a broad range of things, right? Sometimes it feels like when someone dies, what does it mean if I feel a sense of relief, or if I feel some envy, or if I feel angry with someone and I'm mad at them about something that happened, or even about the fact that they're gone. And I think those are some of the things that feel very off limits to folks. And I think part of our role is allowing people to have a space where they can sort of look at these messy and confusing and sometimes and emotions that sometimes don't fit together or like make sense in a cohesive way. They don't have to. We want to just sort of open space for people to notice these things, to feel them, and move through them. At the physical level, especially during acute grief, we'll see very often changes in sleeping patterns, where people either have difficulty falling asleep or staying asleep, or people just feel exhausted. Very often a combination where people feel very tired all the time, but then have difficulty staying asleep. We can see changes in people's appetite. A lot of people might experience migraines or headaches. We can see some digestive issues come up, different energy levels. Some people might be surprised to feel a burst of energy and not quite understand. And there's this image of, a grieving individual laying in a dark room. That might be confusing to someone if they feel this burst of energy and want to sort of check things off, right? That might be a combination of this physical and cognitive dimension, but sometimes it feels really helpful for people to feel effective and get things done. We know that at the physical level, people also experience a lot of joint pain or muscle pain, or just like body aches, body tension, or even rashes. So there's a lot of physical components that come up. And then we also know that people are impacted at the spiritual level. People might have questions about their faith or their spirituality. Losses can really challenge people's spiritual beliefs or their sense of meaning, value, or purpose in life. And so grief can bring about some big spiritual questions. What we see here is that grief is both universal and very individualized. We know that everyone experiences grief, but we also know that everyone experiences it in their own way and for each different loss. So the way we've grieved one loss isn't necessarily the way we grieve others. Because we know that the people we work with are also going to be grieving either the loss of someone by overdose or just other experiences of grief. We want to think also about what does grief look like in the people we serve. So it can show up in inconsistent engagement, right? Someone might come really consistently and then all of a sudden they're not there, or they're just their pattern of how they show up or even what they talk about in session might be altered. We can see changes in people's patterns of substance use. Like I talked about before, we can see that some of the folks we work with might have some difficulty with their focus, attention, or memory. That might show up with us. It might show up with their family and friends. It might show up at work. We might see in groups that someone seems to have a hard time sort of staying present or engaged. People can feel distant and hard to reach, where we feel like we had a really strong rapport with someone, but something has changed and it feels hard to really connect with this individual now. These are things that might sort of cue us to wonder, is this person experiencing grief that they either do or maybe don't know about? We can see what we call emotional lability or just ups and downs. We can also see a sense of feeling numb, that people, you know, if you ask how have you been feeling, just like sort of don't know or don't really feel like they've been feeling anything. People can question some of their basic beliefs and also really be searching for meaning. So this is going to mirror the same way that grief shows up in us, and this is not by any means meant to be an exhaustive list, but I think sometimes when we see some of these different behaviors in our clients, we can be a little bit confused and we don't necessarily know when someone is grieving. And I think very often our clients don't necessarily know, especially when it's not when it's not a fatality, when it's not that someone's passed away, but they're going through some life transition or they're experiencing some other grief that isn't as tangible to them. They might present in some of these different ways with us, and these are some ways that if we see this can kind of cue us to be curious about whether this person might be experiencing grief. So there's a lot of different factors of why people experience grief in different ways than others and why it might be more impactful for some. And so we'll just talk through a few of those factors. One is the relationship with the person who died. How close were we with them? For us as clinicians, we'll talk about this a little bit more. Our relationship with a client who dies is really complicated, right? There's someone who we may have known well, and similarly for people in the program, it might be someone who in some ways you knew really well, but in other ways you sort of didn't know at all. You know, if you work in an outpatient program or a setting where people come to your program, you're not doing community-based work, it's someone who you may have seen weekly or multiple times a week, but you've never been to their home. You have no idea what their, you know, if they have things hanging on their walls. You've never spent time socially with them. You've maybe never seen them If they were a parent, you may have never seen them engage with their children or their partner. And so as clinicians, we have this kind of confusing relationship where in some ways we have this significant sense of closeness and intimacy with people, but it's really limited. And there's a lot of other parts of their lives that are really foreign to us. The cause of death can influence grief. There's types of death, such as overdose, that can feel more traumatic and sudden. And there's different types of death. You know, if there was a prolonged illness, there's just a different response very often to something that's more prolonged than sudden. I think kind of tied up in cause of death is this idea of, you know, were you able to say goodbye? Were you able to be intentional about your last interactions or conversations, or did this happen suddenly? What's your societal and cultural background, and how might that be related to your messaging around grief and your beliefs around what emotions are and aren't okay to express? And do you have social, societal, cultural, or religious customs and beliefs that kind of help guide you through the experience of grief? How do you tend to cope with things? Some people are really spurred to action. Others feel sort of frozen. Some people tend to avoid or need distance. What type of support system do you have, and how well are you able to access it? And then what has happened in the past when people have, when you've experienced loss, and how has that gone? So some of the different things we want to consider. One of the components of grief that I think is important to talk about is this idea of secondary losses. And these are additional losses that come as a result of someone's death. So the term secondary losses isn't at all meant to imply that these losses are less impactful or difficult, but more that they occur because of death. So people can lose tangible things like their home, their financial stability, or their health, or their health care. They can experience relational losses like the loss of support systems or relationships or a sense of belonging. And people can also experience secondary losses to their sense of faith, hope, self-worth, or sense of self. And so these secondary losses are a really normal part of grief, and being able to identify and acknowledge them as an important first step and being able to grieve them. So we know that grief mirrors a lot of symptoms of depression, and I want to be careful that we avoid really pathologizing grief, because it is a really healthy and normal response to loss. And while there isn't a time frame or specific course for grief, we do know that sometimes people get overwhelmed or stuck in their experiences of grief and really struggle to move through the process. And then they might start to use some different behaviors to cope with their grief that can further complicate their grief and start to really interfere with daily functioning. And so that's what we refer to as complicated grief. And so I wanted to put out here just a few assessments that are available to help identify when individuals may need additional support. And so I wanted to share and include these resources, in part just because they're out there and you're likely to come across them and other mentions of complicated grief. But I also want to share them with an abundance of caution around really avoiding judgment of how people experience their grief, how it gets expressed, and for how long. But I do think it's important to know about complicated grief, and I wanted to share some resources around it. So we might be familiar with the idea of stages of grief. which may or may not fit people's experiences and is now a somewhat outdated way of really conceptualizing grief. So we want to explore our own expectations around what grieving should look like and to really present ourselves as being safe and supportive. And when we hold beliefs or assumptions about what someone's grief journey should be, we can unintentionally make it feel really unsafe for people to share these really vulnerable and raw parts of themselves with us. So instead, we want to think about helping people move through these different tasks of grief at their own pace and in their own way. So we want to make sure that people are facing the reality of the loss. And again, depending on some of those contextual factors, like how suddenly this occurred, your relationship with the person, maybe behaviors, especially around overdose. If people were not aware of their substance use, it can be a shock. Different components related to loss can make it more challenging for someone to accept that the person is gone. On top of that, it's then just coping with the pain of that, and sort of the acute, how do I get through this really huge, overwhelming wave that is washing upon me right now. We think after that about how do you begin to then think about living in a world without this person, which I think is related to this other task of engaging in the next phase of life. I think once we've been able to really accept that this person is gone and we've coped with the pain of it, and again, these don't happen necessarily in a linear way, but there's sort of an inflection point of if this person is gone and I'm not, and I'm going to continue to live my life, what does it mean to keep living in a world, and what does the rest of my life look like without this person in it? And for many people, I think what becomes most helpful in that is figuring out how do I maintain a sense of connection to this person? This idea of they're gone but not forgotten, and how can I feel a connection to them and feel like our relationship hasn't ended, it has drastically changed, but they are not gone, and I can still feel a sense of closeness to them. So grief after overdose death can be particularly complex because by its nature, overdose death is sudden and unanticipated. And I think this sudden, unanticipated nature of it can increase the potential for a traumatic response on the part of the counselors, friends, and family who knew the loved one. A lot of times, as we talked about, when people have a period of abstinence or they've been making progress in the recovery or they've been using less, that actually increases their risk for overdose. So a lot of times overdose death happens after a period of abstinence or reduced use, which then really layers people's feelings of grief with a lot of sense of like regret or disappointment. One of the things I hear people talk about sometimes is the sense of false hope, that I really felt like things were getting better for this person, and that feels like maybe a secondary loss, right? Not only is this person gone, but this hope I had for them, for their recovery and for their future, is now taken away from me as well. And there's a lot of pain, and I think very often a sense of betrayal layered in there. And then the stigma of drug use and overdose fatality can really isolate survivors during their grief and mourning. It's really hard for people, I think, to talk about people who use drugs and who died by overdose, to talk about them as whole people. And the totality of their life sort of gets funneled down to their drug use and the fact that they died because of drug use, and the parts of them that were really brilliant or kind or funny or witty and smart or curious, all these other parts of this person sort of fade to the background. And in the way that, you know, when people die from other causes of death, there's a lot of positive stories shared about them and memories. People who are surviving, those who've died by drug overdose, don't have that experience quite as often, and their mourning tends to happen in more isolation. So we're going to hear from a mother who lost her son to drug overdose, and kind of hear about her experience of grief and mourning and the aftermath of drug overdose. So Rebecca, whenever you're ready to play the video, go ahead. So everyone's grief is different, but I think it's really powerful to hear from someone directly who has experienced loss from overdose. And I really appreciate the way that she talks about the complexity of it and the ways that the cause of death being overdose really complicates her experience of grief and adds those layers, like she was saying, of isolation and stigma, shame and judgment. It really sticks with me when she's talking about the more she opens herself up to joy, the more she experiences loss. I also think we can see in the video and her story the ways that she's sort of moved through these different tasks of grief and really feels comforted by maintaining a connection with her son. So again, I think another part that I just want to comment on is just the difference of something like death by overdose versus something like cancer, and just the different reactions from others and forms of support. And that, you know, when someone dies of cancer, not to say one form of death is better than the other, but they're different. And, you know, she's not, she wouldn't be getting questions about, you know, what she may have done that caused them to go down this path, or whether they were getting enough help. And then I think really significantly in the aftermath of the person's death, there's just fewer people who share stories and memories of the person, and especially happy memories or more holistic ones. And we know that that's a really important part of grief that is often lacking when someone dies from overdose. So it's a very unique and layered experience to grieve the loss of someone who you knew as a client. We experience this idea of twin bereavement, where we have our personal loss. We've lost someone who we knew genuinely and who we really cared about and saw frequently. We had a vested interest in their well-being, and we probably thought about them pretty often because they were a genuine person in our lives, and we had an authentic and quite intimate relationship, coupled with the loss and the professional impact and the way that the loss can affect our sense of ourself as counselors. So when people we worked with die from overdose, we might experience feelings of shock, self-blame, anger, or very often diminished confidence or a lot of questions about our clinical abilities. And then when you work in a setting where there's a high frequency of overdose, and we may have experienced multiple client deaths by overdose, we might start to feel sort of numb or dissociated or helpless of like, you know, what's the point? All these people are dying from overdose. We might then replay some of our recent interactions with the person and kind of question if there was something we could have done differently that would have made a difference. So we experience this twin bereavement of both our personal loss, but kind of the grieving and questioning of our clinical confidence and sense of self as clinicians. And then on top of that, our clinical boundaries and professional ethics make it really confusing to know how to mourn. So things we might typically do to grieve aren't really very often available to us as clinicians, because we're probably not going to the funeral, and we won't be talking to their friends and family and other loved ones to share stories and memories, and we aren't really able to reflect with others about our relationship because of the bounds of privacy and confidentiality that still apply even in people's deaths. So this leaves us in a real bind and pushes us to find alternative and creative and very often private ways to process our grief. So we can and need to still find ways to use our personal, cultural, or spiritual grieving rituals to process client losses. So whether that's through our own therapy, without identifying personal information, of course, about the client, through peer support, supervision, or other support groups to be able to process and make meaning of the loss. And I will say this is also where it can be really impactful to staff members to hold a memorial service within the program, because it might be one of the only spaces where staff can really share memories about the individual, again, while still maintaining confidentiality, but to be able to say their name out loud and to be in connection with others who also knew this person who passed. So this is something that I've used with staff before to process client losses and to hold space with them to kind of help process. So I'll leave this in here as a resource, but I think it's just a way to sort of guide through some of the different thoughts and feelings that come up that can help us reflect on the work we did with the person, how they impacted us, and how we might keep a sense of connection to them. So I think it's really important in general. Rituals are a big part of our grieving process. They're a big part of how we move through it and have a sense of community. So we'll kind of wrap up by talking about what that may look like. So I mentioned the memorial service. I think this is one of the most meaningful things we can do in a clinical setting. I really love this idea of encouraging peer involvement in the planning process. If we think back to those different dimensions of grief, this allows some of that cognitive and sort of logistical component. It also gives people a sense of voice and efficacy in situations where they may not have very much. It feels, I think, more authentic and personalized to the individual who passed. And we also know is kind of along the lines of the cognitive piece, but in situations where we feel helpless, very often our instinct is to do something. And what is it that we can do that isn't going to sort of complicate our grief? I think being able to plan a memorial service, like there's a reason that that happens in so many different cultures and traditions, is that in the immediate aftermath of someone's death, we get really busy making plans. And while sometimes that can be experienced as burdensome to some family members, I think in the context of a clinical setting, it's a really nice outlet to give people something to do and to think about, to feel like I can make this happen and I can take care of something. It's a great opportunity to share memories, to work through your feelings of loss, to talk about what parts of them you are going to miss, that you want to continue to carry, and to really make commitments to remembering this person. I have the image here of a butterfly. When I worked in substance use treatment, part of our ritual was that I would make a little butterfly out of paper, and we would all write little messages to the person and just hang them on our wall. And so we still held space for them. They were still a part of our program. We aren't letting go of this person, but they are here in a very different way. But that was, I think, a really useful ritual for our team. We know that it's hard to think about how to support someone through grief, and a lot of people don't feel like they know the right answer. And I think that that's okay. It's okay for us to be awkward and to say, I don't know what the right answer is or what it is that you need. I think it's really helpful when we think about the goal is to support someone, not comfort them, right? We can't fix someone's grief, but we can journey alongside them in experiencing it. And so we're not trying to make it go away. We're not trying to make them feel better, right? They're in the midst of a loss and it may not feel better, but our goal is to help them feel like they're not alone. I like some of these kind of cautionary ideas to be aware of, especially in the context of overdose death, to not blame and ask pointed questions about someone's use. We don't want to minimize this person's death. We don't want to hijack the conversation and make it about our loss. Anything that begins with the words "at least" is probably something that should remain an inside the head thought rather than something we say out loud. And we want to avoid some of these platitudes. The reason for this is a lot of this tends to reduce sort of someone's fullness and their humanity. So we have one final video that kind of talks through how we can support someone in their grief. So once again, Rebecca and Eric, whenever you're ready, I'll let you load up this last video. Okay. So I really love this idea of it makes things better even when they can't be made right. And I think that is a lot of our task as counselors, both for ourselves and the people we're supporting as they experience grief, whether that's grief of overdose, death, or grief of any other loss, because I think as we've talked about, we're very likely to encounter grief in a lot of different ways. And so we want to be able to acknowledge people's grief and make clear to them that we're someone who will be alongside them in it, that we're not trying to take away someone's grief or talk them out of it, but that we're here to look at it and be curious and try to be in connection with them. So as we wrap up, the last piece, which again is not linear, but PowerPoint is how do we integrate a sense of connection into our normal daily life? And so part of it is being able to just say the person's name with those of whom we can, and to share memories of them, to be able to still talk about them and not feel like there's some sort of sense of stigma or secrecy around them, but that we can still talk about them and feel like it's an okay and normal thing to do. We definitely want to continue to talk about overdose, the prevention of overdose, overdose reversal, and the reality of overdose fatalities. I think the more we can become comfortable talking about these realities, the better sort of armored and the more tools we will have to be able to experience them. We want to develop rituals for remembering, ways to solidify memories and stories of the person that are not related to their drug use or to their overdose and cause of death, but to maintain a real sense of connection. Simultaneously, we want to really allow permission for letting go of the person and to think forward and think about what our life looks like from here. And then last but not least, for those of us who are clinicians working with someone who died by overdose, we want to be able to integrate that experience into our professional identity. It's not for better or for worse, it just is that we are people who have worked with individuals who've died from overdose, and that does affect how we move through the world as individuals, but as clinicians as well. So I like to have these couple last questions of how we can sort of make this material last beyond our time today. So I'll let you reflect on that on your own. I know Rebecca has some last things to wrap up, so I will turn it over to her. But thank you all so much for your time and attention and for all you do. Appreciate it.
Well, thank you so much, Susie. I accidentally muted myself. I don't know if you can see in the chat, but people have said that this was a great presentation and really good. And we really appreciate all the work you put into this. And thank you so much for providing all of this great information. So I will let everyone know that we have included Susie's contact information so that you may contact her with any further questions. And once again, Susie, we just really appreciate it and thank you for all the hard work that you put into this. And a couple of items of business to note before we conclude today. Please see the chat panel for a link to today's evaluation. Additionally, when I conclude today's webinar, your web browser will take everyone to an evaluation on FADAA's website. If you want to receive CE credits or a statement of credit for this event, you must complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department Health license prefix and number when you registered for this webinar. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for this webinar and what you have in your FADAA profile in order for you to receive a statement of credit or CEUs. This is the only way we can connect your attendance to this webinar with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com, and the evaluation will close midnight, Monday, May 30th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. If you are unsure how to get a copy of your statement of credit from your journal entry, we have a frequently asked page on our website where you can go and you can get instructions on how to view your journal entries. Thank you for participating in today's webinar, and we'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a good afternoon, everyone.